Cool. So what I was going to do today at the start of the sort of bone and soft tissue block, I know that these tumors can be challenging, and I thought I would start just sort of giving an overall sort of approach. We're not going to go into like super detail today about, various tumors, but I want to sort of show you how I think about them from scratch, and what are the important things to deal with when you're speaking with your clinicians, and what are they looking for in our reports, things like that. If you want to, please speak up, ask questions. I hope that I'm just not sitting here talking to you for an hour. I want you guys to really, ask me what your problems are when you're starting looking at these specimens, and I'm happy to sort of talk you through them. Depending on how far we get, I did put some sample slides together just as like practice, sort of, talking through these differentials. But the main unknowns and the main differentials and stuff are going to come in the subsequent lectures. If, I don't know, Peter said he might pop on. If so, I don't see him yet, but hopefully he'll pipe in as well. I'll have the chat up in case you want to put anything in the chat. So, okay, so here's sort of an approach to, mostly we're going to be talking about soft tissue, but honestly, these concepts can apply a little bit to bone as well, but we're going to be talking more about soft tissue because that's what we just see more of. And so, of course, the things to sort of keep in mind at all times, either before or while you start looking at the slide, are what are the patient demographics? Because we know, of course, things happen differently based on age, occasionally differently based on sex. Does the patient have any syndrome that might cause them to have increased risk for various types of tumors? Have they had any prior biopsies, prior pathology, or prior radiation therapy that may have, put them more at risk for developing a tumor in this location before? Then we, of course, want to think about where it is in the body. So general compartments include the compartments of the soft tissue of the trunk and extremities. Those are kind of a continuum. In that compartment, we have superficial, so anything in the skin, subcutaneous, or sort of suprafascial, so like kind of above the muscle. And then the deep soft tissue, subfascial, intramuscular. When you do have a sarcoma and you are staging it, these compartments do show up on those staging systems. So just to keep mindful. Abdomen or other body cavities versus retroperitoneum, right? So when they say, tumor in the gut, like, is it in a visceral organ? Is it on the peritoneum? Is it floating in the abdomen? Is it in the retroperitoneum, right, which is outside of the abdominal cavity? So tumors that occur in all these things can be different. As I said, could it be in the parenchyma of a visceral organ? Certainly. And then, of course, once we start talking about bone tumors, which I have a whole separate, sort of lecture on, hopefully you've maybe previewed those through the links that I've sent you. Which bone is it? Is it in a long bone, one that has developed endochondrally, or a flat bone that is developed intramembranously? Is it in the marrow or the cortex? Is it in the epiphysis, the diaphysis, the metaphysis? Those all change your differential diagnosis. Specifically, when you're dealing with bone, you of course want to be able to be aware of the radiographic features. Soft tissue is also certainly helpful. I would argue perhaps not as critical as bone, but always try to review the radiographic features of the soft tissue tumors as well. And then once you start looking at it, what is the basic morphologic pattern group, right? So rather than saying, oh, I know this is a fibroblastic tumor, let's just start with, is it a spindle cell tumor? Is it an epithelioid tumor? All right, we'll go over that kind of concept, but this is how I start. When we're dealing with these, what do we want to have in our background knowledge? Well, most are going to be benign. The most benign ones, of course, are going to be a lipoma. The tumors that are superficial and the tumors that are small are generally more likely to be benign. The tumors that are deep and the tumors that are larger are more tending to be malignant, right? Sort of makes sense. And so when we're dealing with malignancies, we're dealing mostly with these sort of extremities trunk, and again, mostly going to be deep rather than superficial. For malignancies, I've just listed sort of the top, 6 types of tumors: undifferentiated sarcoma, lipo, lyo, myxofibrosarc, synovial MPNST, right? So I'm sure during the course of this block, we'll come across these. There is this sort of, intermediate category that's considered locally aggressive or rarely metastasizing meaning less than 2% risk of metastasis. So this is what the WHO has come up with for these tumors that don't really necessarily always behave in a predictable manner. Okay, so in terms of etiology of soft tissue tumors, most are sporadic. Some are syndrome associated, such as NF1. I'm sure you're going to be getting into, I believe Dr. Pytel is going to be giving nerve sheath tumors. And a few, it's thought to be about 5% are radiation associated. What does that mean? That means the patient should have received at least 50 gray, median 10 years from exposure to diagnosis, but really anywhere from 5 to 20. I mean, all of this is reasonable if this patient has developed a sarcoma in a radiation field. This becomes challenging in of course the head and neck, because these people have radiation very frequently for squamous cell carcinomas, and then they pop up with a spindle cell tumor. And the question is this a transformation of the squamous cell carcinoma to a spindle cell carcinoma, or is this a newly developed spindle cell sarcoma, right? And in these cases, sometimes it's only molecular similarities or molecular differences that can answer this question. In the soft tissues, it's a little bit less, of a dilemma, because you're generally not going to be dealing with the spindle cell carcinoma, but in the head and neck, you frequently are. So just be mindful of that. Some of you may have encountered these cases with us at Synod already. Radiation induced essentially doesn't mean it's of a specific morphologic subtype. It can be any morphology. Usually in the deep soft tissues, it's sort of an undifferentiated sarcoma. In the skin, often it's angiosarcoma. Now remember, angiosarcomas can be related to radiation, to sun exposure, right, to lymphedema in breast types of issues. So just sort of general examples. Interestingly, patients who have such syndromes like retinoblastoma, NF1, Li-Fraumeni, right, which is associated with TP53, these patients, number one, are already at risk for malignancies, including sarcomas. Then how do you treat the sarcoma? You may give chemoradiation. Well, then you radiate them and they are developing even more sarcomas, right? So if you ever encounter a sarcoma in one of these people, sometimes the question actually is, do we even treat them with radiation? Because that might predispose them to developing even more, because they're at such a, supreme risk. Does that make sense? Okay. Questions? Peter, comments?
No.
Okay, if you have any, just say so. All right. Ooh. All right. So in terms of treatment, overall, surgery is the primary treatment modality for most sarcomas. For known high grade or very anatomically challenging, compressing on structures, et cetera, that are hard to resect, chemoradiation or just chemo or just radiation may be given in a neoadjuvant setting. Most however, do still undergo just primary resection with further treatment then determined by the pathologic and the clinical parameters. But be mindful that it can go either way. They can get chemoradiation first, they can get it second. When we look at diagnosing these sort of, ways that are proposed in textbooks to think about tumors, in the WHO, sorry, there's an updated one. There's a new, beautiful, like gigantic, bright blue one that if you don't have, and you're interested, I recommend you look into. Both that book and the Enziger and Weiss are sorted by lineage of differentiation. So these are excellent for when you think you have a knowledge about what it might be, and you go to that chapter and you read about it. These are fantastic resources. If you are starting and have absolutely no idea what diagnoses you're dealing with, definitely get the Hornick book, right? So it's histologic pattern based. So go to the myxoid chapter, go to the epithelioid chapter, go to the spindle cell chapter, and read those differentials, and then you can narrow yourself down. I think this is a great way to start thinking about these tumors. And we hope that in the end, you sort of will do both, right? You will have the lineage of differentiation and the histologic pattern sorted out, at least conceptually in your brain, and we can walk through them together. Okay. So what does that mean? So lineage of differentiation is generally things like adipocytic, fibroblastic, myofibroblastic, quote unquote, histiocytic or fibrohistiocytic, smooth muscle, skeletal muscle, perivascular muscle, right? Myoid, vascular, chondro, osseous, nerve sheath, and then just purely uncertain or undifferentiated, which essentially is sort of on the realm of a fibroblastic, myofibroblastic, essentially an undifferentiated or uncertain spindle cell could also be sort of thought of as a fibroblastic, myofibroblastic type of cell if it's spindled, okay? I'm not going to go too much into the lineage of differentiation today, but we will talk about the histologic patterns. So we'll talk about spindle cell, epithelioid. You can consider pleomorphic, round cell, biphasic, mixoid, but I would caution that, anything can be pleomorphic. So, I take pleomorphic with a little bit of a grain of salt. If you recall, those of you who've been around for a bit, you will recall undifferentiated pleomorphic sarcoma was a WHO diagnosis, so UPS, right? Previous to that, it was malignant fibrous histiocytoma, MFH, which has become very out of phase and out of term. But now undifferentiated pleomorphic sarcoma is no longer an UPS, it's just US, undifferentiated sarcoma, right? Because sometimes it's pleomorphic and sometimes it's not. And so just, I'm trying to keep that in mind at all times, okay? So when we're looking at a case, what do we always need to keep in mind when you have a lump, a bump, or a mass forming lesion? Always be broad, right? Is this thing a reactive process or is it truly a neoplasm? And as you know, there are some processes that used to be thought to be reactive, like nodular fasciitis, that subsequently were found to have, clonal genetic anomalies and were now discovered to be self-limited neoplasms, okay? So neoplasm versus reactive may change over time, but what do we know at this moment in time? So, right, we're kind of going with that. All right, if it's a neoplasm, we want to understand whether it's benign versus malignant. And, mostly core biopsy is done to establish that. Those of you who've seen some of our consults, sometimes see people come in, from the outside with a quote unquote cyst, and the surgeon chunks out the quote unquote cyst. And what is it? It's a DFSP. And so, our clinical team here is very cautious, and they won't chunk something out until they sort of have a really good indication of what it is. And so core biopsies or incisional biopsies can be very useful. Importantly, if it's a malignancy, we want to give some indication of the grade, low, intermediate, or high. In soft tissue, intermediate grade 2 is somewhat tending to be considered more like a high. So if you ever are kind of uncertain, you can say, well, it's either obviously high, or it's obviously low, right? So, and if it's obviously low, and it lumps into 2 or 3, then or it doesn't lump into 2 or 3, that's at least sort of helpful. If it's a low grade lesion, or even for that matter, a benign lesion, they will generally resect with clean margins and watch. If it's a high grade lesion, they again may give chemoradiation before resection, in which case they are always going to be interested in the extent of treatment effect and the stage if there's any residual. I guess I will put a caution here about grade. If the patient is treated, the grade is generally established then based on the biopsy rather than on the sub-treatment, post-treatment resection, and then always margins. If they have not undergone previous therapy and we're just dealing with a resection, then certainly we're dealing with, very importantly, final definitive grade, definitive TNM stage and margins that may dictate need for adjuvant treatment. So you may have seen cases where, we call something a low-grade neoplasm, right? Because we're not sure whether it's benign or low-grade malignant. And sometimes this is sticky because sometimes the clinical treatment may change. Sometimes it may not. So this is where having, going to the tumor boards, having an honest discussion with the surgeons and the clinicians is important because, it's helpful for us to understand how their treatment is going to change. And it's helpful for them to understand why we may or may not be certain. And so often we will pursue things like molecular testing, of course, in addition to immunos on biopsy, because that's the most important point. where that diagnosis is going to be made that will dictate treatment in most cases. All right. When we're thinking about margins, generally margins on soft tissue tumors, unless it's, an amputation, should always be taken as a perpendicular section so that we can record the specific distance to the margin. If there is an intact fascial plane separating tumor from margin, even if it's tiny, that should also be reported, because this is considered an adequate margin, even if it's, a millimeter. It is the margin status that predicts local recurrence, okay? And we'll see later, it is the other factors that predict metastasis. Grade predicts metastasis and generally long-term survival, right? So the grading system we use and most institutions use is the French, the FNC-LCC system. And so if you want to have a handy cheat sheet, take this slide, modify it. Of course, you'll have access. I'll give you the PDFs or whatever. One is tumor differentiation score, meaning does this tissue resemble adult mesenchymal tissue? Can I look at it and say, oh yeah, that's a smooth muscle differentiation? Or two is a little bit less certain. Histologic typing is certain, maybe based on immunostains and morphology, but it's not like on H&E, a slam dunk. And then three is just embryonal, undifferentiated, or uncertain, right? So sort of how differentiated is this tumor? Two are mitoses. So 0 to 9, 10 to 19, and then greater than or equal to 20. So pretty self-explanatory. And tumor necrosis, of course, measured pre-treatment, right? So once the patient has treatment effect may take the form of true necrosis. It may take the form of stromal hyalinization or stromal degenerative change or inflammation or abscess or granulation tissue, right? So all of those things might be treatment effect. That's why we don't really grade quote unquote necrosis after treatment, because it could be a treatment effect. 0 for none, 1 for less than 50, 2 for greater than or equal to 50. So you give these points 1, 2, or 3, 1, 2, or 3, 0, 1, or 2 for each of those indicators. You come up with a total score, and then you get a grade. And in this case, as I said, intermediate grade or grade 2 generally clinically sorts with the high. Okay. Oops, wrong direction. What? Oops, I keep going. Okay. So grade. So not all tumors really need to have this grading system applied. Some are sort of by default low or by default high, and we don't even necessarily generally say like well-differentiated liposarcoma, low grade, because it just is. Even low-grade fibromyxoid sarcoma has low grade in the name, for example. Things that are generally high grade. If you make a diagnosis of D. diff liposarc on biopsy, you don't have to say high grade, because it is understood that it is a high grade tumor. So this is all in the WHO in that introductory chapter in the soft tissue component. So have a look at that if you have more, want more information. The TNM staging system, which of course we will then apply to the resections, the way that things are staged by T for sarcomas will vary by site. So if you're in the head and neck, there's a certain T block. If you're in the trunk and extremities, if you're in the abdomen and organs, if you're in the retroperitoneum or the orbit, all of these are different. All of these are in our copath synoptic. So just make sure you're in the right compartment when you're doing the staging. Nodes, more often than not, you will not get any lymph nodes for sarcomas, because they generally don't do lymph node dissections, because these very, very rarely metastasize to nodes. They will take lymph nodes out generally only if there's a clinical suspicion of them being positive. The ones that tend to metastasize are alveolar rhabdoepithelioid sarc and clear cell sarc. You'll note that these are all somewhat, plump or epithelioid in morphology. Interestingly enough, who knows if there is sort of a mesenchymal epithelial transition that's going on that's causing these to metastasize? I don't know. But remember now, for all of the AJCC staging groups, every single organ across the body, every single staging system, just like M, is now not reported unless there is a distant metastasis. So we no longer report M0 or MX. Just like N, we no longer report an NX if there is no lymph nodes sampled. If there are lymph nodes sampled and they're negative, you can certainly give an N0. But if there are no lymph nodes sampled, do not write NX. Just don't write an N at all. So now all of these systems, you only are required to report the T, okay? And you sometimes may not have an M, and you very often do not have an M, okay? Does that make sense? Okay. When you're dealing with sarcomas, you may eventually be dealing with a patient that has a metastasis to a site such as lung, or, you know, a sort of skip metastasis to other soft tissue sites. Sometimes they present with METs. More often they present with a primary and developed METs. Subsequently, as you saw, about 10% have METs at presentation. Okay. So the questions before we move on. All right, this is sort of background.
Sorry,
Yeah,
a little like just silly question, but about grading necrosis.
Mhm.
So we said we only grade like pre-treatment, but of course there's somewhere like the post-treatment necrosis is obviously very important prognostically. We don't use like a 0, 1, 2 for that, right? That's just like a percentage, or it's like a whole different situation.
Right. So correct. In the so when you're dealing with the 0, 1, 2, 0, 1, 2 for the grade for the post-treatment specimens, generally we won't apply that at all, and we'll just say, you know, please see biopsy for, you know, grade whatever. Then in the synoptic, there is a line that says tumor necrosis, and it says, I think like not applicable if treatment effect, if patient has been treated, and then you skip to the treatment effect section, and then it'll say treatment effect, percent, you know, treatment, and percent, you know, viable. And so within treatment effect, necrosis is lumped in there. So like I said, sometimes treatment effect may not manifest as necrosis. Sometimes it may manifest as fibrosis, for example. So yeah, so the necrosis post-treatment goes into the treatment effect line.
Got it. Thank you.
Sure. Okay. Okay. Morphology, terminology. We're going to talk about immunostains, and then, you know, over the course of this whole block, you will hopefully put morphology, immunogenetics, clinical, all of it together. So today we're going to start with morphologic descriptors, right? So what do you do when you're faced with an unknown lesion? And, you know, you don't necessarily have to approach the tumor in this order, like look at the nuclei first. I've just put this in here in the order that I've, you know, it is. So we'll go through all of these features together. But one of the things that's always very important in spindle cell lesions is the nuclear morphology that may sort something into something like your broad categories, right, of nerve sheath, of myogenic, and of fibroblast, myofibroblast. Those are the three big, you know, big hitters that we always want to think about. And so when you're trying to determine what something is, if it's a fibroblast or a myofibroblast, you're generally going to have these sort of oval nuclei with sort of quote unquote open chromatin, which means very pale or very vesicular or very finely stippled, with small nucleoli. You can see, right, pretty much every one of these cells has a nucleolus, but it's small, and they're all very similarly sized. Same here. The cytoplasm of fibroblast, myofibroblast, is very pale, clear, wispy. Sometimes people call these things like tissue culture. Like if you've ever seen, you know, tissues growing on a plate in a culture, sort of this like wispy, haphazard arrangement of cells with these oval nuclei. And here we are, very small pinpoint nucleoli, okay? So how does that differ from muscle, which also tend to have sort of ovoid or elongated, some people say cigar-shaped nuclei, like rather than being, you know, rather than having a belly, they maybe have more of a linear arrangement. You know, how critical that is, I don't know, but these are all smooth muscle images. So, you know, you can see here that smooth muscle isn't always perfectly cigar. Sometimes it's a little bit of a bent cigar, right? But in general, the ends of these aren't like super pointy. They still maintain somewhat of a regular shape. And importantly, the cytoplasm of muscle tends to be more robustly kind of thick and densely eosinophilic. And so sometimes you could make out the difference between the cytoplasmic myofibers, the myofilaments, and the background collagen. And I think you can actually see that in this picture on the left, right? Where this pale pink is the cytoplasm, right? And this more like very subtle, wavy, more dark pink is probably the collagen in between the muscle fibers. Okay, so if you start looking for those tinctorial differences in pink, you'll be able to tell, right? So, for newbies, right, pink isn't pink, right? There are multiple shades of pink. And so just be mindful of these multiple shades of pink. If you're dealing with a well-differentiated tumor of muscle, it is generally going to be intersecting these fascicles at 90-degree angles. So some will be coming out at you and some will be going sort of up and down or across. Okay, so that 90-degree intersection is important. In the picture in the middle, these fibers are actually kind of whirling around a vascular lumen, as you see here. So that structure, it can also be a good hint to smooth muscle differentiation. When we're thinking about something with nerve sheath differentiation, you hear these, characteristic wavy or, buckled nuclei with pointed ends and sort of fine chromatin, and not really those overt nucleoli like we saw in the myofibroblasts. So you can see here that they are more sort of crooked with very pointy ends, pointy end. The only difference I will point out is this one on the right. And those of you who may be looking at each of these three images and knowing exactly what they are, you may sort of recognize that this one on the left is more characteristic for a neurofibroma, which is a little more haphazardly oriented with some sort of wavy stuff in the background. And the one on the right actually does not really have those very, very characteristic pointy nuclei of a nerve sheath tumor. But what it does have is it does have this background sort of fibrillary, linearly oriented matrix. And it has these cells that organize adjacent to or around the matrix, which we may know as a Verrier body in a schwannoma. Okay, so, not all nerve sheath tumors are made alike, but there are features, as you'll learn, that can differentiate them. But keep in mind those wavy or those buckled nuclei in that matrix that may help you. Okay, so if you don't know what you are, what kind of stains are going to differentiate between these three major types of spindle cells? And so sometimes when we've had something that we don't know, like, is it a smooth muscle? Is it a nerve? Let's stain it. Great. Either for fun, if it's irrelevant, like in the background of something, or if it really is the tumor, we'll certainly stain it. Okay. I don't know. Some of you, I remember taking bets with some of you. What's that little, like fascicle over there? Is that smooth muscle or nerve? And sometimes it can be very hard to distinguish. Okay. So don't ever feel bad if you cannot distinguish it. So nerve sheath, of course, is generally going to be S100 and or SOX10 as your starting markers. Smooth muscle and myofibroblast have overlapping immunoprofiles. So generally, I'll start with sort of an SMA because that will catch both of them. And then, of course, you can go based on morphology and based on the presence of additional immunostains to help you. So even myofibroblasts can stain, don't forget, with Desmond. If it's really diffuse and really strong and really thick, you may start to think more of a smooth muscle type of tumor. Other things you can add on that will only be positive in smooth muscle are going to be such as caldesmon and smooth muscle myosin heavy chain, which are thought to be negative in myofibroblasts, if that makes sense. So I put my table of myogenic markers here. I refer to this quite often. I think it's quite helpful because it will allow you to quickly gauge what you're dealing with, right? So as you can see, SMA is very good because it will catch the smooth muscle. It will generally catch the myofibroblasts. I put myoepithelial on here as well because always, I'm always in a head and neck world, right? And so that being said, where's the second place that myoepithelial tumors occur? In the soft tissue, okay? So don't ever forget that you can have tumors with myoid and epithelial differentiation in the soft tissue, which is why I think it's important to have it in this chart. What myoepithelial will do that's different than the rest, of course, is it will have epithelial, right? So it will have a keratin or an EMA, an epithelial membrane antigen, right? What skeletal muscle is different than the rest is that it will have nuclear markers of skeletal muscle differentiation, which are myogenin, which we have, or MyoD1, which we do not have, just different antibodies. Okay, so when you're thinking about these things, I like to put this note in here. What is a fibroblast or myofibroblast? That's basically a spindle cell, right? That has those characteristic morphologic features. You cannot prove as anything else, either by morphology or immunohistochemistry. If it has some myogenic markers, like a little bit of SMA, you can call it a myofibroblast instead of a fibroblast, okay? And I know that Dr. Kraus likes to discuss the sort of tram track appearance of smooth muscle actin staining in myofibroblasts, meaning sort of membranous accentuation along each of those membranes. So kind of in parallel, tram track, all right? So that's what he's talking about. Comments, questions? Okay. Now we will look at sort of cell shape and cytoplasmic characteristics. And so when a cell has abundant cytoplasm, you may refer to it as polygonal or eosinophilic. When a cell has eosinophilic cytoplasm, especially if the nucleus is eccentrically placed, right? You might think about something that is plasmacytoid or rhabdoid. You know, cells that are rhabdoid in appearance don't necessarily have to have striations like skeletal muscle, but they should have sort of a very eccentrically placed nucleus with very, very, very eosinophilic cytoplasm next to the nucleus. And then sometimes the cytoplasm is just sort of wispy and nondescript, and it sort of pokes, you know, in various directions from the nucleus. And this can be considered almost a stellate appearance, which may suggest a fibroblast or a myofibroblastic type of cell, although not always. Things to recall on cell shape and cytoplasmic contents are, if something is epithelioid and it is a mesenchymal neoplasm, mesenchymal epithelioid neoplasms with tend to more likely express keratins or EMAs, okay? As opposed to spindle cell mesenchymal neoplasms, okay? So perhaps they contain some cytoplasmic filaments, some keratins in there that affect the morphology, affect the shape of the cytoplasm, and therefore there's that morphologic immunohistochemical correlation. So things like epithelioid sarcoma, epithelioid hemangioendothelioma or epithelioid angiosarc, even epithelioid MPNST, malignant epithelial rhabdoid tumor, sclerosing epithelioid fibrosarcoma. Sometimes these can have keratins, some more than others, right? To diagnose epithelioid sarcoma, you basically have to have keratin. You know, to diagnose an epithelioid MPNST, you may or may not have keratin, if that makes sense, right? When you see something that has rhabdoid or eccentric cytoplasmic different, you know, morphology, you're certainly going to want to think about something truly plasma cell, right? Truly something plasmacytic or plasmablastic. And of course, you may want to show heme. You certainly want to think of something with true skeletal muscle differentiation, like a rhabdomyoma or a rhabdomyosarcoma. But always now in today's day and age, what we're seeing quite a lot of, right, are these chromatin remodeling complex aberration associated sarcomas or carcinomas. That have loss of the SMARCA1 gene, which is the INI1 protein, or the SMARCA4 gene, which is the BRG1 protein. And so whenever you see something that may have rhabdoid cells, honestly, just throw a Desmond on there for skeletal muscle differentiation, and throw your INI and BRG on there for chromatin remodeling things. What I will say is, you know, for skeletal muscle differentiation, right now we're not dealing with SMA, right? We're not dealing with smooth muscle actin. Let me just pull up that chart again, right? We're basically dealing with Desmond or MSA. Desmond is pretty good. So if something has skeletal muscle differentiation, more often than not, it will have Desmond. Once it has Desmond, then you can go ahead and, you know, probe for the myogenin, but that would be the algorithm for skeletal muscle, okay? Here's my table on epithelioid tumors. I'm not going to go through it in depth, but it'll be there for your review. Take it, use it, modify it as you need. But just remember, you know, the significant prevalence of keratins in tumors with epithelial differentiations. And for that matter, the prevalence of loss of INI1. So, you know, our chromatin remodeling complex, right? So things like epithelioid sarcoma and malignant rhabdoid tumor are essentially defined by the keratin expression and loss of INI1 with different clinical presentations, okay? In myoepitheliomas and malignant myoepitheliomas and epithelioid MPNST, half of these can also have loss of INI1. All right, so then you're dealing with other markers or other morphologies that are going to help sort these out. Okay. We haven't yet talked about the small round blue cell tumors as a sort of morphologic pattern, but remember that, small round blue cell tumor is a morphologic pattern. And I wanted to have this slide up here for a moment of discussion on those. So, of course, whether you're a child or an adult, whether you're in the soft tissue or the bone, your differential diagnosis may change. But I've tried to put some of the main hitting small round blue cell tumors on here. So let me see if I can get my annotations up for a second. All right. So if you're dealing with something in the bone, that's small round blue cell, chances are you may be dealing with something like a Ewing or a peanut. Is my annotation showing?
Yeah.
Okay, thank you. Especially if you're a child. Remember that Ewing sarcoma, / peripheral neuroectodermal tumor can happen in children and can happen in adults. Generally in kids, it's often in the bone. Okay, in the bone, we can also be dealing with a small cell variant of osteosarcoma. These are very rare, but they do occur. And so recall that, don't ever put off osteosarcoma if it doesn't look characteristic, right? There are variants of osteosarc, including small cell. If you're in a bone and it's neither one of those, you may be dealing with a B-core rearranged sarcoma. These are all these three are very similar. They're sort of Ewing's-like tumors that do not have the EWSR rearrangements. They either have the B-core rearrangement, the Bs tend to happen in bones, and the CIC or the chick rearranged tend to happen in soft tissue. But they can all be clued in by the fact that their CD99 is somewhat, less robust than Ewing's. I will also put in desmoplastic small round cell here as a Ewing's-like small round blue cell tumor because it also has similar morphology and they actually will treat it. They'll treat desmoplastic small round cells essentially exactly like a Ewing's. But this has divergent differentiation to, expressing EMAs, to expressing myogenic markers, to expressing neural markers, to expressing T1. Okay. And then if you're in a kid, you also want to think about rhabdo, especially in the sites in which rhabdo is more common, the GU tract, the head and neck. Okay. This can also present as a small round blue cell tumor. Note that. Okay. If you're in an adult, you may now more be thinking about a lymphoma, right? So, like I said, Ewing's, rhabdo, even osteosarc, certainly synovial sarc, certainly round cell liposarc can occur in adults, but really, really lymphomas are most often going to be in adults, not really so much in kids. You're mostly dealing with leukemias, right? Same with round cell liposarc, you're mostly dealing with the disease of adults. Synovial sarc, you can be in an intermediate sort of young adult age group. And synovial sarcs, even though they're generally spindled, can also have a high-grade round cell thing. So, I'm not sure if we're going to do a round cell lecture this block. I'm just not sure if anyone's doing it. So, I put this here just in that occasion. I don't have a column I apologize for the genetics. I can add that in, but recall that in most round cell tumors, if they have a genetic problem, we will be looking for it, right? So we'll be looking for EWSR like either FLY1 or ERG, right? In here, we'll be looking for the chick rearrangement, the B-core rearrangement. We'll be looking for, if it's rhabdo, right? We'll be looking to differentiate embryonal versus alveolar with the PAX-FOX. If it's desmoplastic small round cell, it's going to be EWSR WT1. If it's synovial sarc, it's going to be the SYT SSX. If it's osteosarc, you're probably just going to find a P53. And if it's round cell liposarc, we're going to be dealing with the DDIT3 FUS, and we will have a fatty tumor lecture, so we'll get more into that later. But I'm happy to add a genetics column here and send this out to you modified. Okay. Awesome. Questions? Okay. So moving on to the next thing that we're going to talk about, other than nuclei, cell shape, stroma, right? So different cells deposit or may deposit different types of stromal materials. There's a fine bluish type of stroma, which we can generally refer to as myxoid. Ooh, what happened there? As myxoid. When you see a spindle cell or epithelioid tumor with myxoid stroma, you may be thinking of either something potentially fibroblastic, myofibroblastic, like a quote unquote myxoma. If the myxoid matrix is a little bit more dense, you may be thinking of something like connective tissue mucin that could be present in a myoepithelial tumor. And then if it's really dense and high, sort of glycan-y, you may be thinking of actual cartilage, okay? Of course. If something is very dense and pink and ropey, you are probably going to be thinking that it's collagen. In this case, generally something fibroblastic or myofibroblastic. Now, don't forget that collagen can sometimes mimic osteoid. Collagen tends to be very sort of wavy and ropey, and you can see internal kind of fibrillations or structures to it. Osteoid tends to be very thick and dense and like surround the neoplastic cells in its sort of warmth, right? And sometimes the osteoid calcifies, right? And so you get these purple chunks of calcified osteoid matrix, okay? Of course, something that has true osteoid production has osteoblastic differentiation, and something that has true cartilage production has chondroblastic differentiation. But that doesn't necessarily mean that the tumor is an osteosarc or a chondrosarc or an osteoma or a chondroma. Sometimes remember that tumors such as, for example, MPNST, right, can have heterologous differentiation. D. diff liposarc can have heterologous differentiation to these other mesenchymal stromal types. You can also have, for example, heterotopic ossification that's not neoplastic at all. It's just a response to injury, okay? So all these things are important to remember when you're looking at tumors. It's a matter of what your differential is, how developed the differentiation is, and the clinical setting in which it makes the most sense. Okay. Architecturally, the patterns that we come across are this haphazard, again, perhaps the word tissue culture comes in mind, that might be more of a fibroblastic or a myofibroblastic process, such as a nodular fasciitis or even a scar, for example. This sort of tight intersecting fascicles or whorls tends to suggest a quote unquote storiform pattern, which may mean something fibroblastic or myofibroblastic like a DFSP, something nerve sheath like a perineurioma. Certainly my bullets here are not exhaustive, but they are giving you some of the more common things that you should think about when you see these patterns. When you think about something that has very long or sweeping fascicles that is fasciculated or herringbone, you may think about something such as a fibrosarcoma, a synovial sarcoma, even an MPNST. If the fascicles are very blue, as you see on the bottom inset here. If the fascicles are more pink, like you see in this larger picture, you might even think about something, I forgot to write it here, but like a desmoid tumor, right? Like a fibromatosis, okay? So depending on whether the fascicles are long and pink, lots of cytoplasm, right? Or long and blue, minimal cytoplasm, you may be diverging your thought process, okay? All right. Of course, there's always, not only are there, architecture, stroma, but there's vessels within the stroma. And so these so-called thin-walled, branching, dilated vessels where the tumor cells come right up to the endothelium, right? There's no myoid muscular wall. It's just endothelium, and maybe it's a pericyte, okay? These are so-called hemangioparasitoma-like or HPC-like or staghorn. Recall that hemangioparasitoma has essentially in most circumstances been changed to solitary fibrous tumor, which happens in the lungs, which happens in the soft tissues. Is HPC still the term in the brain?
No, not anymore.
Okay, what is it called?
Solitary fibrous tumor.
Awesome, fantastic. So HPC-like vessels are still HPC-like vessels, but now it's solitary fibrous tumor. Awesome, very good, because they all are morphologically and genetically essentially identical. There is still a different quote unquote hemangio, or more often referred to as glomangioparasitoma, that has a very similar differential diagnostic appearance. Some of you may have seen these so-called GPCs. They occur pretty much exclusively in the sinonasal tract. And they are of true pericytic differentiation, meaning they are perivascular myeloid tumors that express muscle markers, and they have different genetics from from solitary fibrous tumors, sorry. Other tumors that have HPC-like vessels can be synovial sarc, can be MPNST. So sometimes the vessel, right, can clue you into the diagnosis. When you have something that the buzzword, right, might be small, compact, anastomosing network or chicken wire, you might think about something like a myxoid liposarcoma, which is what's pictured here. Of course, that's not the only tumor that has these types of vessels, but it's one of the more common ones you're going to see. You may see vessels that are curvilinear, so sort of straight and then curved, and not very gaping, but again, sort of very, very small and not very anastomosing. So they're single curvilinear vessels. That might suggest something like a myxofibrosarcoma in the right background. If you have something on the top here that's very thick-walled and muscular, like I said, and there's whirling around a vascular lumina, that might refer to something like an angioleiomyoma or some kind of other hybrid tumor of vessels and muscles. Remember that there are not only angiomas, there are not only leiomyomas, there are angiomyolipomas and angioleiomyomas, right? So you can have hybrid tumors where it is thought that the neoplasm is composed of not just a bystander vessel, but where the vessel is actually part of the neoplastic process, if that makes sense. Hopefully that wasn't too confusing. And then, of course, features of malignancy are going to be things like necrosis, punctate necrosis. This would be, is it a small area of necrosis surrounded by essentially viable tumor? That's probably true necrosis. Or is it a more large area that's associated with histiocytes, fibrosis, hemosiderin? That might more likely be a prior biopsy or a prior surgical procedure. Mitoses should always be taken in context of the overall tumor. And you can have many, many morphologically typical mitoses in a highly proliferative benign thing, right? Like nodular fasciitis. But once you start seeing an atypical, a tripolar, a tetrapolar, right? These are essentially not okay for something benign. This is essentially malignant. Borders, I will take with a grain of salt, because a pushing border can be a sarcoma and an infiltrative border could be a benign tumor. So always take border in the context of the other remaining features of the tumor. Okay. When you're dealing with an unknown neoplasm and you want to throw some stains on it, 850. Okay, good. We always want to think about keratin markers, right, for epithelial differentiation, nerve sheath or melanocytic differentiation, which is of course going to be your S100 and SOX10. Tumors that show purely melanocytic differentiation will, of course, in addition to the above, also show the bottom. We tend to not use MITF very much anymore because it's not as specific as any of the others. So I haven't seen Kraus or anyone really use an MITF for a while. So since we have SOX10, which is also nuclear. We already went over the myogenic ones a bit. I have a more detailed slide on the vascular markers, so I can go over that. And then of course, the list is endless, but broadly, like if you don't know what something is, you may want to start here. So how do we start with keratins, right? So CAM 5.2 is a low molecular weight. It tends to stain non-squamous epithelium, like glandular epithelium. High molecular weight, or CK5-6, tends to stain squamous epithelium or squamoid, basaloid things like urothelium or like myoepithelium, okay? AE1, AE3 is more broad. It's tend to stain both low and high, most epithelia. And then EMA stains both, as you know, epithelial and non-epithelial tissues, right? So we know that EMA can be positive in our things like our low-grade fibromyxoid sarcoma, our sclerosing epithelioid fibrosarcoma. So these can be markers specific. If they are positive in spindle cell tumors, they may actually lead you down a very characteristic path, okay? As opposed to an actual keratin, which may lead you down a spindle cell carcinomatous path, if that makes sense. The S100s and the SOX10s can, of course, also be present in things other than melanocytic or nerve sheath differentiation. So it's thought that granular cell tumors show perhaps some nerve sheath differentiation. Myoepithelium, based on its embryologic derivation, also contains both of these. Fat and cartilaginous tumors can also have S100. Salivary pancreatic acini, just like can have SOX10, not just in the myoepithelium, but also in the actual like acinar cells. So keep in mind that these are not 100% specific, but perhaps can be regarded in certain circumstances as sensitive. Okay, vascular markers. Consider CD31 and 34 as your cytoplasmic markers. 31 tends to be a little bit more specific because it won't stain your other tumors like SFT, DFSP, spindle cell lipomas, right? But it may stain in the background some plasma cells. So always sort of look at the morphology of the cell that's picking something up. Characteristic, pitfalls are like plasma cells, are mast cells, right? Those things can pick up anything. Background tumor infiltrating lymphocytes, for example, that are not tumor cells can stain with, lymphoid markers. You don't want to call something a lymphoma because there's a lot of lymphocytes in the background, right? So always be careful and look at that's why you have a counter stain, right? That's why you have a blue counter stain on your IHC. So you can always look at the negative cells or the positive cells, okay? D240 is also going to be cytoplasmic, but it's going to be more directing you towards a lymphatic differentiation. But as you know, it can be present in many other things like meso, right? Your nuclear markers are going to be FLY1 and ERG. So I quite like ERG. So my two go-tos for true vascular differentiation are basically CD31 and ERG. But know that none of these are 100% specific. So everything should always be taken in context. All right. We're not going to so much talk about any of the translocations or mutations or genetics today. Let me rephrase that. I frequently have to look these up because if it's not a tumor you're commonly used to dealing with, you may not have it on the tip of your memory. So don't ever feel bad for looking something up. But if you have it on your differential before you come to sign out, look it up because we may end up ordering the fish for a particular thing in any given circumstance. Some of these translocations have immunomarkers that are associated with them, right? So for example, NAB-STAT in solitary fibrous tumor has a STAT nuclear immunostain, which we may start with first before progressing to fusion. And many of them do not, right? Many of them do not have corresponding markers, but many do. Okay, so, of course, when you have absolutely no idea what you're doing, you'll probably want to think broadly, right? Carcinoma, melanoma, lymphoma, sarcoma. Sarcoma being so broad that there's not like an immunomarker for sarcoma, right? There's a few immunomarkers for carcinoma, keratins. There's a few immunomarkers that are more sensitive for melanoma. There are certainly markers that can tell you that it's a lymphoma. But once you've exhausted all of those, then you have to deal with a subtype of sarcoma, right? So then you're going to say, all right, could it be angio? Could it be lipo? Could it be whatever? All right. I'm sure that makes sense to you. The one thing I will point out that we quote unquote upstairs often think about in lymphomas, especially if we're dealing with an epithelioid tumor, you may actually want to consider an anaplastic large cell lymphoma, right? Those tend to present histologically more of an appearance to a carcinomatous almost looking thing or a melanomatous looking thing with the abundant cytoplasm. So, you know, you might, if all else fails, you know, obviously show heme, but consider throwing a CD30, for example, or an ALK if you want to think about an anaplastic large cell lymphoma type of process. You know, if after all that you have absolutely still no idea, we have not infrequently resorted to molecular as either I have some idea what it is, but I need to confirm it with the molecular, to this is really tough. I have almost, you know, I have some idea of what it is, but really we need molecular to actually confirm the diagnosis. So any of those circumstances might occur to you. So how do we think about this on the back end? I know you guys don't gross, you know, core biopsies really very much anymore, but if you are ever asked to consult, I would always say split the cores up into multiple blocks, right? So don't throw all of the cores into one block. Because if you do 30 immunostains, 50 immunostains, and then you want to do molecular, you're done, right? You can't. So you can do 30 immunostains on one block, 30 on another, 40 on another, and then you still have one block left for molecular, right? So split them out, okay? Always process them either as undecalcified or EDTA decalcified if needed. Don't let these things touch HCl, as you probably know. What are our molecular options, and what can we do in non-decalcified or EDTA decalcified tissue? We can certainly do Onca Plus, right, for next generation sequencing, mutations, copy number changes, sometimes fusions, certainly things like tumor mutational burden, which may indicate if high, something like an ultraviolet signature, microsatellite instability. We found, you know, many answers on RNA fusion, even though not all fusions are validated, all that they find are reported on an investigational basis, which is great. So we have those answers in our reports. If it's a very specific thing that we want to know, that we want to be resulted quicker, we'll often do FISH, right? This is a faster answer. If we have a very specific gene or a couple of genes that we're looking for, we can ask for, you know, break apart of EWSR, or, you know, dual fusion for EWSR, you know, FLY1, things like that, depending on the clinical circumstances. We generally send either to Mayo or to Julia Bridge at ProPath for these. And if there are any immunostains that we don't have, always check the Mayo Medical Laboratories website, because they do tech onlys. And a lot of you have done these where we send them on stain slides, they send us back the stain and we report it, right? So it's essentially literally tech only, we interpret it. I guess we were out of time, so I won't go through these practice things. Good, I'm glad we took up all the time. So if you have questions, let me know. I'm happy to give you the recording and the I guess PDF/PowerPoint. Anybody have any questions?
In the chat either. Thanks. Yeah, if you could do the PDF or PowerPoint with the molecular, that'd be great for us studying boards.
I'll add those, sure.
Awesome. Thank you. Thank you. All right.
And all of my PDFs from prior years are on the M drive. So don't feel shy about poking around in there. Okay.
Sounds good. Thanks.
Thanks.
Bye.
Thank you.